Bismillahirrahmanirrahim. The topic I'll be presenting today is asthma and COPD. I'll be presenting this topic under kind supervision of my professor, Dr. Saira Afzal. Quote of the day: if Allah can turn night into day, then surely Allah can turn into the darkness uh, of your life into happiness and prosperity. Trust in Allah. Learning outlines, definition of COPD, epidemiology of COPD and asthma, forms and stages of COPD, types of asthma, pathogenesis of COPD and asthma, pathophysiology, clinical features and symptoms, diagnostic tests, prevention and management of COPD and asthma, difference between COPD and asthma, recent updates, MCQs. Learning outcomes. At the end of this presentation, participants will be able to describe definition, epidemiology, pathogenesis, pathophysiology, diagnostic tests, and management of COPD and asthma. Definition of COPD. Gold Guidelines 2017 modified the definition of COPD as follows. It is common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitations that is due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. What is COPD? A set of lung diseases that limits airflow and is not fully reversible. COPD patients report they are hungry for air, usually progressive and is associated with inflammation of lungs as they respond to noxious particles or gases. Potential preventable with proper precautions and avoidance of precipitating factors. Symptomatic treatment is available. Epidemiology. COPD is third leading cause of death in America. In 2010, 12.1 million in US, 10.1 million Americans, 4% in Washington, 9% in Albania, reported worldwide 64 million in 2004 worldwide, 3 million in 2005, 90% die in low and middle income countries. So here's a diagram. It's kind of like, it's to show the statistics. So WHO statistics about worldwide deaths due to respiratory issues in 2000 and 2016. So here it is being shown COPD is at 5.4% and 5.7%, and asthma 0.7% and 0.9%. So here's another flow diagram, and this diagram is basically showing the different symptoms related to COPD, their prevalence, and it is being presented in different countries along with Pakistan. So here it is 18.5. Main forms of COPD. COPD forms, there are two main forms of COPD: chronic bronchitis, which involve a long-term cough with mucus; emphysema, which involves damage to the lungs over time. Most people with COPD have a combination of both conditions. Causes of COPD: smoking, lack of alpha-1 antitrypsin, exposure to certain gases or fumes in the workplace, exposure to heavy amounts of second-hand smoke and pollution, frequent use of a cooking fire without proper ventilation. Pathogenesis. Pathogenesis of chronic bronchitis and emphysema. Tobacco smoke, air pollution. It would cause continual bronchial irritation and inflammation, and breakdown of elastin in connective tissue of lungs along with alpha antitrypsin deficiency. So then it would lead to chronic bronchitis and emphysema. Chronic bronchitis is basically bronchial edema, hypersecretion of mucus, chronic cough, bronchospasm. Emphysema is destruction of alveolar septa, airway instability. Airway obstruction would be there. There would be air trapping, dyspnea, frequent infections, abnormal ventilation perfusion ratio, hypoxemia, hypoventilation, cor pulmonale. Pathophysiology: abnormal inflammatory response of lungs due to toxic gases would lead to response occurs in the airways, parenchyma, and pulmonary vasculature, leading to narrowing of the airway taking place. Destruction of parenchyma leads to emphysema. Destruction of lung parenchyma leads to an imbalance of proteinases, antiproteinases. This proteinase inhibitor prevents the destructive process. Then there would be pulmonary vasculature changes, thickening of vessels, collagen deposit, destruction of capillary beds. It would lead to mucus hypersecretion, cilia dysfunction, airflow limitation, cor pulmonale, right ventricular failure, leading to chronic cough and sputum production. So what are the stages of COPD? Stages of COPD are mild COPD or stage 1. Mild COPD with FE1 is forced expiratory volume in 1 minute, about 80% or more of normal. Moderate COPD or stage 2, moderate COPD with a FE1 between 50 and 80% of normal. Severe COPD and or stage 3 is severe emphysema with a FE1 between 30 and 50% of normal. Very severe COPD or stage 4, very severe or end-stage COPD with a lower FE1 than stage 3, or people with low. So again, this slide is also presenting the stages of COPD. So you can see mild is FE1 over FEVC, that is forced expiratory volume, in 1 minute, or forced vital capacity less than zero point 0.7, and FE1 is more than 80% as predicted. So here again, mild, moderate, severe, and very severe, these are the four categories. And depending upon these ratios, you can differentiate between them. Symptoms: cough with or without mucus, fatigue, many respiratory infections, shortness of breath, dyspnea, that gets worse with mild activity, and wheezing. Easily fatigued, COPD has following clinical features: easily fatigued, frequent respiratory infections, use of accessory muscles to breathe, orthonic, corpulmonale, thin in appearance, wheezing, pursed lip breathing, chronic cough, barrel chest, dyspnea, prolonged expiratory time, bronchitis, increased sputum, digital clubbing. Chronic bronchitis, emphysema. Chronic bronchitis is clinical. The clinical diagnosis would be like by the following features. That is like daily productive cough for 3 months or more in at least 2 consecutive years. Overweight and cyanotic. The clinical features would be these. The patient would be overweight and cyanotic, elevated hemoglobin, peripheral edema, and rhonchi and wheezing. Emphysema, pathological diagnosis, permanent enlargement and destruction of air spaces distal to terminal bronchioles. X-ray would be showing hyperinflation with flattened diaphragms. And when the patient would present, he would be older and thin with severe dyspnea, and the chest would be quiet. Emphysema is basically dilated air spaces beyond respiratory arterioles. Types are century SNR, smoking. The reason is smoking, pan-SNR because of the deficiency of alpha-1 antitrypsin, and paraseptal and irregular. So clinical features are again cough, wheezing, respiratory acidosis, weight loss, pulmonary function tests would reveal reduced FE1. Complications are pneumothorax. Death from emphysema is related to pulmonary failure with respiratory acidosis, hypoxia, and coma. Right-sided heart failure, corpulmonale. Chronic bronchitis is basically persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. Smoking is related. Forms are simple chronic bronchitis, chronic mucopurulent bronchitis, chronic asthmatic bronchitis, chronic obstructive bronchitis. Morphology would be enlargement of the mucous glands, increased number of goblet cells, loss of ciliated epithelial cells, squamous metaplasia, dysplastic changes, and bronchogenic carcinoma. Inflammation, fibrosis, and resultant narrowing of bronchioles, coexistent emphysema. Clinical features are prominent cough, production of sputum, COPD with hypercapnia, hypoxemia, and cyanosis, cardiac failure. Diagnosis: COPD would be diagnosed by the following symptoms: physical examination, sample of sputum, chest X-ray, high resolution CT, pulmonary function test. The major is spirometry, arterial blood gases test, pulse oximeter. Prevention: ways to prevent are as follows: stop smoking if you smoke to prevent further damage to your body. Smoking cessation is critical for all severities of COPD. Avoid or protect yourself from exposures to secondhand smoke and other substances such as chemical vapors, fumes, mist, dust, and diesel exhaust fumes that irritate your lungs. Management: how it is treated: COPD can be managed but not cured. Treatment is different for each individual and is based on severity of symptoms. Early diagnosis and treatment can slow progress of the disease, relieve symptoms, improve an individual ability to stay active, prevent and treat complications, and improve quality of life. What medications are used to treat symptoms? They are as follows: short-acting bronchodilator inhalers such as salbutamol, long-acting bronchodilator inhalers such as salmeterol or formoterol, bronchodilators, theophylline tablets, relaxes muscles around airways, oxygen therapy helps with shortness of breath. Treatment options for COPD is basically self-management, education, and smoking cessation. Then use bronchodilators, inhale corticosteroids, pulmonary rehabilitation, oxygen, and then surgery, depending upon the severity. So differentiating asthma from COPD, these are the major differences. In asthma, age of onset is mostly less than 30. In COPD, it is more than 40. Family history is usually there. Uncommon in COPD, cough most prominent, nocturnal, post-exercise. In COPD, it's early AM, history of atopy often. In COPD, it's uncommon, bronchodilator reversibility, complete, nearly. COPD is partial, steroid responsiveness strong. COPD usually weak. Progressive deterioration uncommon. It's typical in COPD. Anticholinergic responsivity. Beta agonist better. Best first line. Beta agonist responsivity very good, and anticholinergics are better in COPD. Purulent sputum is uncommon in asthma and it's typical in COPD. Smoking history is variable in asthma and it's always essential in COPD. Asthma. So, bronchial asthma, chronic relapsing inflammatory disorder characterized by hyperactive airways leading to episodic reversible bronchoconstriction owing to increased responsiveness of the tracheobronchial tree to various stimuli. It has been divided into two basic types, extrinsic asthma and intrinsic asthma. Epidemiology, in 2001, 7.3% increased. In 2010, 8.4% increased. From 2001 to 2009, asthma per worldwide deaths by asthma is 180,000 annually. Classification of asthma, extrinsic and intrinsic. Extrinsic is initiated by type 1 hypersensitivity reaction induced by exposure to extrinsic antigens like food, pollen, dust, etc. Subtypes include atopic, occupational, allergic, bronchopulmonary. Aspergillosis develop early in life. Intrinsic is initiated by diverse non-immune mechanisms, including ingestion of aspirin, pulmonary infections, cold inhaled irritants, stress, and exercise. No personal or family history of allergic reaction developed later in life. So here is in this diagram, you can see the global asthma rates. They are being shown here. Bronchial asthma. Some potential asthma triggers are allergens, pollen, pet denders, fungi, dust, mites, cold air, pregnancies and chemicals, pollutants, cigarette smoking, strong emotions, exercise, respiratory tract infections. Extrinsic asthma. Atopic asthma is the most common form, begins in childhood. Other allergic manifestations, allergic rhinitis, urticaria, eczema. Other family members also affected. Pathogenesis of bronchial asthma, exaggerated bronchoconstriction, two components, chronic airway inflammation, bronchial hyperesponsiveness. The mechanism have been studied in atopic asthma. Pathogenesis of atopic asthma, Ig-mediated reaction to inhaled allergens elicits acute response within minutes, a late phase reaction after 4 to 8 hours in the airway, initial sensitization to antigen allergen with stimulation of type 2 helper T cells and production of cytokines, interleukin 4, interleukin 5, and interleukin 3. Pathogenesis of atopic asthma, acute phase response, being 30 to 60 minutes after inhalation of antigen, mast cells on the mucosal surfaces are activated. Mediators produced are leukotrienes C4, D4, and E4, induce bronchospasm, vascular permeability, and prostaglandins D2, E2, F2 induce bronchospasm and vasodilation. Histamine induce bronchospasm and increase vascular permeability. Platelet activating factor cause aggregation of platelet and release of histamine. Mast cell tryptase inactivate normal bronchodilator. Mediators induce bronchospasm, vascular permeability, and mucus production. Pathogenesis of atopic asthma, late phase reaction, recruitment of leukocytes mediated by the product of mast cells, including eosinophil and neutrophil chemotactic factors, interleukin 4, interleukin 5 induced type 2 helper T cells, subsets of CD4 positive cells, platelet activating factors, tumor necrosis factor. Other cell types are involved, activated epithelial cells, macrophages, and smooth muscles. Pathogenesis, late phase reaction would be the arrival of leukocytes at the site of the mast cell degranulation lead to release of more mediators to activate more mast cells, cause epithelial cell damage. Eosinophils produce major basic protein, eosinophilic ketogenic protein, and eosinophil peroxidase toxic to epithelial cells. These amplify and sustains injury without additional antigen. Non-atopic asthma triggered by respiratory tract infection, including viruses and inhaled air pollutants. Sulfur dioxide, ozone, positive family history is uncommon. Serum Ig normal, no other associated allergies. Skin test negative, hyper-irritability of bronchial tree. Subtypes drug-induced asthma and occupational. Clinical signs are classic asthmatic attack, dyspnea, persistent recurrent cough, wheezing, chest tightness, difficult expiration, progressive hyperinflation of lung and mucus plug in bronchi. Status asthmaticus, there would be severe cyanosis and persistent dyspnea may be fatal, may progress to emphysema. Diagnosis is based on spirometry, breathing test, which measures the amount and rate at which air can pass through the airways. Bronchodilator reversibility testing, relaxing tightened muscles around the airways and opening up airway quickly to erase breathing. Other pulmonary function tests are diffusion capacity, chest X-ray, and arterial blood gases, shown oxygen level in the blood. Management would be beta 2 adrenergic agonists. So first we'll be using bronchodilators, asthma medications may beta 2 adrenergic agonists, rapid onset, quick relief of bronchoconstriction, X in minutes, last 4 to 8 hours, treatment of choice for acute attacks. If used too much, causes tremors, anxiety, tachycardia, palpitations, nausea. Short-acting may albuterol, proventil, Ventolin, and continuous would be beta adrenergic agonist nebulizer therapy may be given. Bronchodilators Theophylline relaxing bronchial smooth muscle anti-inflammatory effects. Asthma drug therapy. Anti-inflammatory drugs are corticosteroids, beclomethasone, suppress inflammatory response. Inhaled form is used in long-term control, systematic form to control exacerbations and manage persistent asthma. Uh, May 7th, World Asthma Day. Now recent updates. Status of studies investigation asthma COPD overlap in Korea are reviewed. Abstract. There is considerable number of individuals who exhibit features of both asthma and chronic COPD, defined as asthma COPD overlap. Many studies have reported that these patients have a greater burden of symptoms, including cough and dyspnea, and experience more exacerbations and hospitalization than those with non-ACO COPD or asthma, although diagnostic criteria for the ACO COPD have not yet been clearly established. Their clinical significance remains to be determined as interest in ACO grows. Related studies have been conducted in South Korea as well. The present review summarizes ACO related studies in South Korea to better understand Korean ACO patients and guide further research. Several cohort studies of asthma and COPD and population-based studies for ACO were reviewed, and the key results for demographics, clinical features, lung functions, biomarkers, treatment, and prognosis were summarized. Air pollution as an early determinant of COPD. Abstract. COPD is a progressive and debilitating disease often diagnosed after 50 years of age, but more recent evidence suggests that its onset could originate very early on in life. In this context, exposure to air pollution appears to be a potential contributor, although the potential role of the air pollution as an early determinant of COPD is emerging. Knowledge gaps still remain, including an accurate qualification of air pollutants, number of pollutants, qualification, and exact composition, or the one exposure, one disease. Quantified and exact composition, or the one exposure, one disease concept, which might limit the current understanding. To fill these gaps, improvements in the field are needed, such as the use of atmosphere stimulation chambers able to realistically reproduce the complexity of air pollution, consideration of the exposome, as well as improving exchanges between pediatrics and adults lung specialists to take advantage of reciprocal expertise. This review should lead to better understanding of the current knowledge or air pollution as an early determinant of COPD, as well as identify the existing knowledge gaps and opportunities to fill them, hopefully. This will lead to better prevention strategies to scale down the development of COPD in further generations. Now, time for MCQs. A 50-year-old overweight smoker presents with history of cough productive of mucoid sputum in every winter for last 3 years. The most likely diagnosis is A. Bronchial asthma, B. Bronchiectasis, C. Bronchogenic carcinoma, D. Chronic bronchitis, E. Pulmonary tuberculosis. Anyone?
B.
No, it's D. It's chronic bronchitis. A young girl presents in OPD with complaints of nocturnal cough and shortness of breath, which disturbs her sleep. A diagnosis of bronchial asthma is made. The most important investigation to confirm the diagnosis is chest X-ray, eosinophil count, Charlie lung function test, D serum IgG levels, E sputum examination. It's Charlie lung function test. MCQ number 3, Mr. Stokes is a 60-year-old man who is seen in his annual review at the respiratory clinic. He has COPD currently controlled with inhalers. His pulmonary lung function test results are as follows: FVC 3.40, predicted value 4.23 liters, which is 80%, FE1 1.4, predicted value 3.25 liters, 47%, FE1 over FVC ratio 0.45. What severity of COPD does Mr. Y has based on the PFT findings? A mild, B moderate, C severe COPD, D very severe, E the findings are not consistent with the diagnosis of COPD.
C.
Yeah, that's C. You can see as I mentioned the slide as well. So as FVC is it's 80%, and you can see the pattern. FE1 is 1.4, which is 47%. So as per the slide, it would be severe. Mr. Wilson is a 64-year-old gentleman who saw his GP with shortness of breath and a productive cough. He has attended the practice multiple times in the last few years for similar problems, particularly in winter. He explains he normally coughs a lot, bringing up a small amount of white sputum, but currently is much more shortness of breath and productive and producing large volumes of green sputum. He's an ex-smoker with a 20-pack history. His GP treats him with a course of antibiotics for a chest infection, which is very effective. She also refers him for the pulmonary function test. Given the recurrent nature of his symptoms, the result of the PFTs post bronchodilation are as follows: FVC is 3.58, which is 95%. FE1 is 1.9, which is 65%. FE1 over FVC ratio is 0.53. What is the pattern consistent with? A. Normal lung functions. B. Restrictive lung disease. C. Moderate COPD. D. Mixed disease. E. Severe COPD with mild response to bronchodilation. Anyone?
D.
No, it's C.
E.
It's C. It's C. That is moderate COPD. You can see FVC is 95% here. Peter is a 64-year-old man. He has become unwell over the past couple of days. He feels very under the weather, tired, feverish, and and has a productive cough of green sputum. He ignored this for a couple of days, as he often has a smoker cough. He has a 100-pack-year history and has continued to smoke despite recent increased shortness of breath. On exercise, he has seen his GP recently and has referred him to hospital for further investigations. His wife became very concerned about him and has brought him to emergency. What is the most appropriate first line investigation for this gentleman? A. Sputum culture.
Beta.
B. Chest X-ray. C. Spirometry, peak flow, or C. Reactive protein.
Chest
Yeah,
X-ray.
it's beta.
Beta.
Yes, it's chest X-ray. MCQ number 6, a 60-year-old man with a history of weight loss presented with progressive dyspnea on exertion. He gave a history of cigarette and alcohol consumption. On examination, he had barrel chest investigation showed FE1 1.4, FEC 3.0, total lung capacity 7. What is the most likely diagnosis? A. Chronic bronchitis. B. Emphysema. C. Bronchial asthma. D. Cryptogenic fibrosing alveolitis. E. Bronchiectasis.
Alpha.
Um, it's beta. You can see the old man with weight loss. In emphysema, the person would present with weight loss and barrel chest as well. MCQ number 7, a patient is presenting with chronic obstructive pulmonary disease. The patient has a chronic COPD, a chronic productive cough with dyspnea on exertion. Arterial blood gases show a low oxygen level and high carbon dioxide level in the blood. On assessment, the patient has cyanosis in the lips and edema in the abdomen and legs. Based on the nursing knowledge on the patient's symptoms, you suspect the patient suffers from what type of COPD? A. Emphysema. B. Pneumonia. C. Chronic bronchitis. D. Pneumothorax. C. Pulmonary TB. Anyone? It's Charlie, bronchitis. MCQ number
C.
5-year-old man presented with progressive dyspnea on exertion. He gave a history of cigarette and alcohol and consumption. Alcohol consumption on investigation, he is diagnosed as a case of emphysema. A patient with emphysema may present with all of the following symptoms except A. Barrel chest, B. Hyperinflation of the lung, C. Hyperventilation, D. Hypercapnia, E. Weight loss. It's anyone? It's Charlie, hyperventilation.
C.
It's Charlie, yes. 9, the term blue bloater is used to describe patient with pulmonary, A. Pulmonary hypertension, B. Left side heart failure, C. Emphysema, D. Chronic bronchitis, E. Asthma. Anyone?
C.
It's delta, it's chronic bronchitis. The blue bloaters are basically in chronic bronchitis. MCQ number 10, 23-year-old man, male with history of asthma presented to ER with shortness of breath and wheezing at ER. They cite oxygen supplementation. What is the best step to do in the patient to take him out of the this exacerbation state? A. Albuterol, B. Anticholinergic drugs, C. Steroid, D. Delta albuterol and antibiotics, and E. Pulmonary function test. It's Charlie, steroids. Here is the key. Here are the references of my presentation. And thank you so much. Here is the link. Kindly like and subscribe.